Dr. Parikh, Dr. Manning, distinguished delegates, ladies, gentlemen, friends. It's a very great honor to be asked not only to participate in this conference, but to deliver an oration in the name of the late Dr. Padmanabhan. I had the privilege of knowing him after his retirement from the government of Tamil Nadu, when he worked with the National Health Systems Resource Center, NHSRC, and I was working in the health sector in my state of Uttarakhand. And I remember being struck, even at my very first meeting with him, of how differently they seemed to do things in the south from the way in which we were used to working in the northern states. And I was privileged to call him my friend. He was always very, very kind to me and very responsive to any question I had. Even when I moved from the state to the Ministry of Health in the Government of India, he continued to remain a great support and strength. It was a matter of great sadness for all of us in the public health sector that he passed away so early. And as I said, I'm honored to be asked to speak in his memory. One of the most important things about Dr. Padmanabhan and the work he did was he represented the public health movement in India at its best. Certainly the fact that he came from a state which had an established public health machinery, and in this respect was so different from most other states in India. But it was not just the fact that he worked in Tamil Nadu, it was his educational background and his own beliefs and his own principles were very strongly that of a public health man. He would not be categorized into as a specialist of any sort. He was first and foremost a public health man. And I reiterate this point because that is one very, very important feature within the entire area of health policy and practice that we have lost. For 60 years and more now, India has consistently followed a pattern that sought to set aside the traditional family medicine-based, public health-based approach. Starting from the early 1950s, India built a health structure, a pyramidical structure, starting with sub-centers and primary health centers at the base, community health centers, district hospitals, medical colleges and teaching hospitals, tertiary care institutions. And also a corollary of this structure of healthcare institutions was state-based cadres of medical officers who worked their way up this chain of institutions. Now, all of you here are familiar with the subject. I don't need to go into details of how and why this approach to healthcare delivery through a public system has not succeeded in delivering what it was supposed to do. But what I would like to do is to spend just a few minutes talking about what I see are the very, very big issues that confront us in the health sector in India today, and how those of you who are a part of the family medicine movement would want to think about addressing some of these issues. Now, no discussion of health policy can ignore the reality of what the disease burden is. And again, at the risk of repeating what everyone in this hall is familiar with, we face battles on many fronts. We have not yet got rid of communicable disease. So whether it is malaria, whether it is dengue, whether it is HIV and AIDS, there are battles to be fought on several fronts. Polio and smallpox being two great successes. Polio more recently and smallpox 40 years ago. Successes that came out of a bringing together of resources, manpower, technology, research. But clearly, those successes have to be offset against the fact, as I said, of widespread prevalence. So that is one set of disease issues we are fighting. Again, non-communicable disease, into which category I would also include mental illness, represents a very, very big disease burden. So whether it is diabetes, whether it is cardiac disease, whether it is cancers, mental illness again, these are huge areas of concern where we are under-equipped, where there is a lack of adequate data. And then there is maternal and child health, the status of which is best indicated by maternal and infant mortality statistics. As all of you would know, we have not met the Millennium Development Goals on either under 5 mortality or on maternal mortality, and we are now looking at even more stringent Sustainable Development Goals to be met by 2030. Some of you would be familiar with the very sharp criticism recently made by Professor Richard Horton, the editor of The Lancet, who, talking about India's maternal and infant mortality situation, made the harsh but true observation that no civilized society can allow its mothers and daughters to die. And so this is just a reflection at a very, very basic level of the fact that we are still fighting disease and mortality at a very, very basic level. It is also true that we do not have an adequate or sufficiently detailed mapping of disease. Much more intensive work is needed in this area. And to my knowledge, there is no serious work happening. I'm aware, for instance, that less than 10% of all cancers in the country are part of any organized cancer registry program. NIMHANS in Bangalore, the National Institute of Mental Health and Neurosciences, has just begun a nationwide survey and assessment of the prevalence of mental illness. So clearly there is a lot of data collection analysis that is needed. But then that does not, of course, take away from the fact that we are aware of the reality of these diseases. So there is a very, very huge disease burden. And that has to be the backdrop of anything we say. The other very, very big issue in health policy, in health care delivery in India, is the question of health human resources. And whatever we may say, the fact remains that there is a severe shortage of almost every category of health professional that we need in the country. So whether we're talking about the ANM, the auxiliary nurse midwife in her sub-center, or whether we're talking about a super specialist in an AIMS or a JIPMER or a PGI, we do not have a sufficient number, and more importantly, we do not have them in the locations that we want them. So the range of health professionals is very wide. This includes every kind of allied health professional, technicians, laboratory technicians, X-ray technicians, ICU technicians, nurses, nurse practitioners, psychiatric nurses, ICU nurses, cardiac care nurses, doctors, specialists, surgeons, anesthetists. Any category you look at, we do not have an adequate number. We fail the WHO standard of what the desired number per head of population should be. And as I said, we don't have them where we want them. The last figures I saw seem to suggest that something like 45,000 medical graduates are turned out every year from our medical college system. This is the base MBBS degree. It would be useful to know where these people are and what they are doing. Linked to this is the question of what is the kind of education that they have received. There are 406, or maybe it is 416 medical colleges in the country now, and well over 50% of them are private. And for those of you who are familiar with medical education situation in India, you would know that the issues involved in private education, the quality of education received in private institutions, the fees charged by these institutions, these are all very difficult and thorny areas. The bottom line basically is that we can only expect those persons who have graduated from government medical colleges to be available for government service, for the simple reason that those who have passed through a private college would simply not be able to afford to spend their lives working for government if they had to pay the costs of what their education has meant to them. So there is also the very big question of the quality of teaching in private institutions as different from public institutions. Clearly, many things have gone wrong in medical education. And while this may not be the time to dwell on what those reasons are, it is clearly necessary that if we are to address our requirement of trained and qualified doctors at the primary health center level, then something we need to do something very different from what we are currently doing. Where I said we have something like 45,000 MBBS graduates every year, there's something like 22 or 23,000 postgraduates. Again, we do not have them in the specialties we need. We do not have anything like a satisfactory number of MDs in family medicine, or geriatric care, or palliative care, or psychiatry. We have huge numbers in radiology, orthopedics, obs and gynae, which are clearly the much more lucrative professions for doctors to follow. So there is a very, very big issue here. So we are producing numbers of people, we're not quite sure where they are. One of the many things at which the Medical Council has failed is in keeping track of where registered doctors are or what they are doing. So we do not have them in the disciplines that we need. We have them in the kind of specializations for which there is a great demand in the major private hospitals in the big cities. We have them in the specializations where a very lively practice can be established, but we do not have them in the specializations that we need in primary health centers and district hospitals. So this is a very, very big problem. And the third and large issue that confronts us in health policy and practice today is the whole question of health financing. Who is to pay for health care? Traditionally, India has followed the line that providing health care is the responsibility of the state. And it is a view that I certainly believe in, and it's a view that many people believe in, that healthcare, certainly primary healthcare, is the responsibility of the state, which is to say that primary health centers across the country should be fully equipped, fully staffed, and providing the service that should legitimately be expected at the primary care level. It is believed that roughly 70% of all health transactions are at the primary level. And a robust, well-functioning, publicly driven health system should address this 70% requirement. Certainly, there are public responsibilities at the secondary and tertiary care levels also, most importantly in the area of setting up government medical colleges. The space that we have ceded to the private sector in medical education needs to be recovered. But we also need investment in big tertiary care centers, the All India Institute, for instance, institutions like NIMHANS, JIPMER, PG at Chandigarh, great centrally funded public institutions of tertiary care and medical education. So these are responsibilities that the state, in my opinion, cannot avoid. And this discussion in India at the present point of time is poised, I'm not quite sure exactly where. If one were to refer to the 12th plan document that came out in 2012, it makes very, very bold statements, makes a commitment of substantial volume of funds for the health sector over the 5 years from 2012 to 2017. We do know from 3.5 years experience within the planned period that that order of funding has not been received. In fact, we have received somewhat less than 1/3 of what the plan document promised. There is also a debate in India right now which seems to suggest that much more of the responsibility for healthcare, including primary care, needs to be that of the private sector. And that private facilities would provide the care, and that this care would need to be purchased from the private facility, and the people beneath a certain income level may be given an insurance cover which would enable this to happen. This debate is by no means closed, because almost everyone who works in primary care is aware of the great barriers to access to care which exist in India today, and are aware of the fact that many of these barriers will not and cannot be overcome through private sector intervention. There are thousands, if not millions, of people in this country who cannot afford any kind of payment for health care. 75 to 80% of all health spend even now is what they call out of pocket. And there are huge numbers of families that are not going to be in a position to afford this. We have learned from now 8 to 10 years experience of insurance schemes in the country that insurance-based care will not provide all the health cover that is needed. Quite simply, the insurance schemes we have currently functioning provide only for indoor treatment, leading to a lot of useless hospitalization, useless surgeries, useless cesarean sections being performed. Insurance cover does not take care of outpatient treatment, which is where the bulk of healthcare is going on. So there are very, very, very big problems. So I've placed before you 3 big areas that ought to be of fundamental concern to all of us working in the health space: disease burden, human resources, and finances. And now, when we talk about the need for family medicine, we are, as I said earlier, we are fighting a very major battle in the interest of a robust public health movement in the country. Because what we are asking for is well-staffed health facilities. At the end of the day, I would like to see not a specialist in a primary health center, but I would like to see a well-qualified doctor without postgraduate qualifications, but who has been trained to handle a range of complaints and diseases that may be brought before him or her, is in a position to offer the first line of treatment and to take a call on referral where necessary. And this is precisely what we don't have at the present point of time. So we need to see a movement back to a more wholesome and robust MBBS education, which equips an MBBS doctor with the skills needed to either establish a practice privately or to work in a government primary health center and basically handle the range of complaints that appear. Such a doctor should not feel the need to rush off and do a postgraduate course, which is the trend in India. Such a doctor should really be in a position to say that she would look at a postgraduate program 5 years down the line, after 5 years of experience in solid family medicine out of a primary clinic. So that is something we should be looking at. We need many, many more government medical colleges offering many more seats in family medicine and geriatric care, areas which are currently not very popular. At the very least, we expect government medical colleges to offer these specialties. We may not be able to immediately impact on private medical colleges to do so. Dr. Batra from the National Board of Examinations is here. He may tell us at some point about how the contribution of the NBE system towards promoting family medicine. That's an important area of concern for us. And I think the third thing is all of us who are interested in family medicine must prevail on government that a certain minimum level of public funding, both of healthcare and medical education, has to continue. It is too important a debate to be left solely to what you might call the policymakers. And I think everyone here, as practicing doctors, physicians, teachers, public health people, have a job in making this call, and which is why a conference such as this one is extremely important, because in bringing together specialists from around the world, people with experience in running strong, vibrant public health systems, a recommendation from a gathering such as this carries weight and may act as an influence on people making decisions within government on how much money is to be put into what sector and for what purpose. But I think one thing is very, very clear, which is that we have to keep up the fight for what you might call person-centered healthcare. That at the very least, a doctor and a nurse and some supporting staff at the primary care level, it is not a lot to ask for if one puts one's mind to it. Providing a basic amount of care, a strong extension system, especially in the context of the rising prevalence of non-communicable disease in our country, is more important than ever before that we have an ongoing health extension system. One important lesson that we have learned in India over the last 10 years is how much work can be done by someone like an ASHA, the accredited social health activist created under the National Rural Health Mission. And the ASHA is not a trained public health worker, she is a health facilitator. But as a health facilitator, many states, many ASHAs have shown us what remarkable work can be achieved in in being a health facilitator. And drawing on the ASHA model, there is a strong case to be made for a health extension system with public health workers in every block and every district, as happens in Tamil Nadu, a system with which Dr. Padmanabhan was very closely associated. So this is to sum up what I've been trying to say. I think our objective is clear. We should be looking for a strong, well-staffed, well-functioning primary healthcare system working out of primary health centers set up by the government. If such institutions were to exist and staffed by qualified doctors and nurses and allied health people, further supported by a troop of public health extension workers, paid for by the government, that would be an essential and extremely important first step towards tackling the disease burden. This would need, of course, a reorientation of the way in which we look at medical education in the country. But that, again, is a task for government to do. So these are very, very big tasks. But we can hope that with goodwill and good faith, India will make some progress in this direction. Thank you.